Well, today's program, I think, is going to be an interesting one. LaShanda Penn comes to us from the nursing faculty of Winston-Salem State University in North Carolina, while she is currently working on her PhD at the University of Virginia. She already has a number of awards to her credit, including those of being John Hartford Scholar at Duke University and NIH Genome Scholar at her present institution. Now, I first heard her give a talk at the Southern Association for the History of Medicine and Science meeting last year in Louisville, and immediately knew that I wanted to bring her here as part of our Reynolds Lecture Series, since her talk was so well crafted and visually informed. And here she is. After hearing her, I think you'll agree with me that we have here a scholar who is able to inhabit and even flourish in the varied realms of science and history. Ladies and gentlemen, please join me in welcoming LaShanda Penn as she presents Health Care for Blacks in the Jim Crow South. Thank you.
Thank you, and thank you for having me. I'm excited about being here. And I'll start my talk here. In his second inaugural address in 1937, President Roosevelt spoke of 1/3 of the nation as ill-housed, ill-clad, and ill-nourished, and that many poor rural families were also just plain ill. The Great Depression was a period of economic crisis in United States history, but was particularly trying for those in the rural South who were poor and in desperate need of nursing care and health education. The political environment of the New South was one of strong regional and local loyalty, and resistance to change from outside reformists trying to initiate programs aimed to protect the most vulnerable. Federal funding prompted public health reform through the development of new public health services for poor Southerners living in poverty. In spite of all this change, there remained a need for unique programs for the most vulnerable group, Blacks living in poor physical, financial, and social conditions amidst a racially divided region. The purpose of this paper is to explore the history of public health nursing in the rural South during the 1920s and 30s, with a focus on North Carolina and Mississippi. I'll explore the dynamics of rural health nursing, the effect of the economic crisis on public health, and additional barriers to health care for Blacks related to utilization of services, education, training, and race relations. The paper will highlight challenges to the health and well-being of Blacks living in the rural South during this period in history. In 1932, Franklin Roosevelt promised a New Deal for the American people that included a variety of federal relief programs intended to provide financial support as incentive to end the Great Depression. In spite of the confusion created by the many programs, regulations, and requirements, President Roosevelt gave a strong message that it was the responsibility of the federal government to ensure a minimal quality of life for all citizens, including adequate health care for all. The Federal Emergency Relief Act was one of many programs that had a direct effect on nursing, especially in the field of public health. In 1933, the North Carolina Emergency Relief Act began operation in North Carolina after receiving $2.7 million of federal funding. North Carolina Public Health Relief Projects provided employment for 216 registered nurses who focused on health promotion and disease prevention by giving general health education talks, training lay midwives in sanitary techniques, providing home health nursing, amongst many other public health services. The role of economics and personal finance in our society is often linked with physical health and wellness. In a book about a rural Appalachian community, the following quote was made by Mary Williford of the Frontier Nursing Service. First, the economic level of the people is so low that they cannot provide for themselves even the minimal amount of medical, nursing, and health care requisite for the protection of the individual or the community. Second, such people, except in unusual instances, are getting a negligible amount of health protection. Third, the natural resources of the country in which these people live cannot in the immediate or near future be developed to such an extent as to raise the economic level to a point where they can provide adequate medical, nursing, and health care for themselves. Rural areas were hardest hit during the early 20th century due to drought, poor farming conditions, decreased government subsidies, and generally poor economic times for everyone. The majority of Black Americans lived in the South, inhabiting the rural areas rather than the urban areas. The health status of Blacks was impacted by medicine, economics, and race. No particular diseases seemed to be more prevalent in one race or another until the factor of environment was considered: cleanliness, education, access to care, and income. The environmental factors created a situation that made good health extremely difficult for Blacks. Black families, half of whom were employed in agriculture as farm tenants or laborers, were especially vulnerable to shifting conditions in agriculture. The period up to the 1920s was a prosperous time for Black farms, but farming conditions during the 1920s affected all involved in agriculture, especially Black farmers that were not landowners. In November 1932, a prominent white planter in Pitt County, North Carolina, wrote, "A good many Negroes have lived in farmhouses rent-free this year, and in most cases have been given land for garden. They have lived hard. They're in much worse condition than a year ago." The impact of the economic depression on already difficult living conditions was a lower standard of living, resulting in inadequate food, shelter, clothing, health, and morale for Blacks living in the South. The economic barrier to adequate health care was intensified by Jim Crow laws. Because of color, Blacks had limited access to many medical facilities, even when they could pay for them. In 1935, Michael Davis, PhD, chairman for the Committee on Research and Medical Economics, reinforced this observation. He wrote, "In the South, race represents definitive barriers to the use of certain services, particularly in institutions. And the medical care of the Negro in the South has the further characteristic that it is largely a problem of rural areas." The early years of the 20th century saw significant growth in the field of public health nursing. From 1924 to 1931, there was a 33% increase in public health agencies and a 42% increase in the number of public health nurses. The majority of public health nurses had been employed by local agencies, but subject to the availability of private funds from local sources. Fortunately, New Deal funding permitted local agencies to re-employ many nurses who had become unemployed earlier in the crisis. Local agencies were an important part of the public health workforce because they were able to deliver much-needed nursing services to those living in remote areas. States in the South, like North Carolina and Mississippi, were largely rural areas, and the health of the people often lay in the hands of local health departments. For example, in 1931, only 1/4 of the counties in North Carolina even had a public health nurse. A similar trend can be found in many other southern states. The unique challenge for the rural South was the lack of facilities available to provide care for those in remote areas of the community. In the North, urban neighborhood clinics arose from the need to decentralize public health work, bringing it from health departments to the homes and neighborhoods of the people needing the services. The clinics played a role of prevention of disease, health education of the public, and collaboration of health workers. The more efficient neighborhood clinics were able to combine the services of health and welfare agencies. According to Ira Hiscock, professor of public health at Yale School of Medicine, the problem of disease prevention is closely linked with social service, especially among families of low economic level, and the health and welfare workers may aid each other in the solution of their interrelated tasks. Prior to 1912, when the Red Cross established its first public health nursing division, the Town and Country Nursing Service, visiting nursing services were mainly available to urban dwellers. Town and Country Nursing Service offered neighborhood health services to the rural poor. The American Red Cross in 1912 instituted a program for 1 year to provide nursing services to citizens living beyond the original scope of neighborhood health clinics. The program supplemented the care of country practitioners whose demand far exceeded supply in the rural areas. The Red Cross's mission was to first recruit and train rural nurses, encourage local districts to take on the new responsibilities, and then move on to a new community in need of similar services. In the rural South in the 1930s, public health nurses were particularly important in providing care and were influenced considerably by the Metropolitan Life Insurance Company. In 1909, William Wald established a partnership with Metropolitan Life to offer visiting nurse services to improve the health of industrial workers and low-wage earners. Metropolitan Life established a Metropolitan Nursing Advisory Committee in 1934, which joined the services of visiting nurses, boards of directors, leaders of professional nurse associations, and public health professionals to improve the quantity and quality of public health nursing. What made Metropolitan Life Insurance Company's contribution more unique was that prior companies provided care for their employees, whereas Metropolitan Life provided nursing services to all of its policyholders, thereby expanding care to some 7,000 plus communities across the United States. The initiative of the Henry Street Settlement and Metropolitan Life Insurance Company in large cities like New York and Boston impacted the field of public health nursing by showing the value of visiting nurse services in improving the health of the public, and subsequently impacted public health delivery throughout the rural South. Large insurance companies provided public health education for blacks in the South. The Metropolitan Life Insurance Company, North Carolina Mutual Life Insurance Company, and various other insurance companies have impacted members of the black community that would have otherwise been overlooked by existing public health efforts. Blacks had available written materials that educated them on basic matters of disease prevention, such as hygiene. In addition, the insurance companies offered periodic physical examinations and nursing services, thereby extending the reach and impact of public health reform to a population desperately in need of care. A major challenge of medical care for blacks and poor whites in the South was access to care in an environment of tense race relations. In the early 1900s, there was a common belief that blacks were inferior and uneducated. In 1900, Professor Barringer of the University of Virginia argued against educating blacks, saying that they were a race of peasant farmers and laborers who had little value outside of warm climates where they would typically perform manual labor. Jim Crow laws reinforced the sentiment that the white race was supreme and successfully disenfranchised blacks in areas of government, voting, housing, employment, and education. The supremacist sentiment toward blacks can be found in papers addressing health problems of rural blacks. Ms. Ann Doyle, a member of the Instructor Visiting Nurse Association of Baltimore, wrote about the need for health education and services for blacks because the health of blacks affected all races living in close proximity. Ms. Doyle wrote about the blacks she cared for, saying that they were dependent, irresponsible, mentally immature, generally shiftless and idle, the males spasmodically employed and solely in the lowest forms of labor. Ms. Doyle expressed quite candidly in her paper her belief that rural blacks were more of a challenge because of limited resources such as schoolhouses, housing, employment, medical providers, and sanitary living conditions. She stated that rural blacks were suspicious of white doctors and nurses, and they felt neglected by the system. She discussed the culture of blacks living in the rural South and the things nurses needed to understand in order to provide adequate care, build trust, and improve communication. Although she described blacks as inferior to the white race, her dedication and compassion as a public health nurse seemed to prevail. Ms. Doyle's final recommendation in her paper was that legislative bodies recognize blacks as human beings entitled to the same privileges as whites: sanatoria, hospital care, proper housing, and improved educational facilities. The same sentiment was widespread amongst public health workers that the health of the most vulnerable directly affected the health of the nation. With North Carolina Mutual Life Insurance Company reporting higher rates of mortality and morbidity amongst blacks, widespread education measures were initiated to improve health outcomes for blacks. In addition, progressive public health workers sought to dispel the myth that differences in disease incidents were because of race, rather a result of correctable environmental conditions. While statistics reflected a decline in the overall death rate, the far-reaching effects of poverty on the health and well-being of the poor rural farmers manifested itself through increases in nutrition-related diseases like pellagra. Ms. Edith McNeil Holmes was a black public health nurse in Halifax County, North Carolina, who visited poor farmers and their families who were suffering the results of poverty, hunger, and pellagra. Ms. Holmes recalls her joy when doctors in Raleigh, North Carolina supplied her with powdered milk and brewer's yeast that she would deliver to hungry families in her district. She told one story of how she helped one family plagued with illness and hunger. She wrote, "I recall one family in particular during this time when there was so much plague. I found the mother and daddy sick in bed with lots of little children just sitting around. The older children were in town working. I opened their lard stand and all I found was a little bit of grits, a small piece of fat meat, and a third of bag flour. I headed straight home to Weldon and shared my story with the health director. It was late in the evening then, so the next morning I went to the A&P store. I gave the manager $2 of my own money, and I told him I wanted him to add about $7 from the store to it, and filled a box full of food for that family. They were the happiest people you've ever seen. There were a lot of hungry people back in those days." Ms. Holmes exemplifies the spirit of public health nurses who use community and personal resources to care for their patients as if they were family. Ms. Ida Holmes was a black public health nurse who represented a small minority of the nursing profession. North Carolina in 1931 employed 165 public health nurses, only 20 of whom were black nurses. In Mississippi, there were a total of 35 public health nurses, with only one of them being a white nurse. Because of race relations and mistrust of whites, blacks were often wary of seeking health care. There were a limited number of doctors and nurses per 1,000 people compared to the ratio of doctors to people in the urban areas. In fact, in 1929, 1 in 6 blacks who died did not seek medical care at all during the last 6 months prior to their death. In 1934, 5 years later, that number rose to almost 1 in 4. Low income directly correlated with insufficient medical care in both races, but was more pronounced in the black race. The issue of supply and demand was compounded by the fact that there were fewer black nurses available, and poor blacks were less likely to seek services because of lack of trust. The limited supply of doctors, nurses, dentists, and hospitals in the remote rural regions of the South further complicated the health needs of blacks. Dr. Michael Davis wrote that the sick man may not seek the doctor and he may be afraid of the hospital in the Journal of Negro Education. This situation further justified the need not only for public health nurses working in the field, but for black public health nurses who already had the trust of the community at highest risk for illness and death. Franklin Nichols from the Department of Education Measures argued strongly for the benefit of better opportunities for black nurses in the South. He believed that improving the health of blacks was a necessity for the health of the entire population and could be accomplished through adequate hospitalization, less discrimination in health services available to blacks, and more aggressive public health care by black doctors and black nurses. Black nurses were often assumed to have had inadequate training and therefore were often paid less because of that assumption. However, in many states, black and white nurses took the same licensure examinations regardless of where they were trained, so differences in salary could not be justified solely based on training. Black nurses did not have the same opportunities for specialty training in public health nursing because of the limited number of training facilities for public health in the South that were open to black nurses. Therefore, their opportunities for entry into the field of public health, which was a specialty within nursing, were limited. Ms. Elizabeth McMillan Thompson, one of the first African American public health nurses in North Carolina, remembered her public health work during the New Deal era as follows. Of course there was smallpox. The first week I was here, Tarboro, North Carolina, I vaccinated over 3,000 black people. What was so particular about it was that the local doctors would refer a case to us as smallpox. And after I went to visit the patient, I would discover it wasn't smallpox at all, but syphilitic measles. We began to pick up many of our venereal diseases this way. As I recall, the first problems we addressed were smallpox, venereal disease, tuberculosis, and poor sanitation. Many of the families had no sanitary facilities, so one of our big projects in the early 30s was to provide privies for the tenant farmers. We'd go back sometimes a month later and the privy hadn't been used at all. So we ended up showing them how to sit on the seat. Then you had to show them how to keep the snakes from going in and making homes, and how to keep the spiders out so the children wouldn't be bitten. Truly, the public health nurse's care extended well beyond the scope of disease treatment and into the holistic care of a person, family, and community. Public Health Service was a leader in establishing public health nursing services to the nation. The U.S. Public Health Service worked in collaboration with state health departments through a public health nursing consultant employed by the federal government. Each region of the nation had available the services of this nurse consultant to assist in the use of relief nursing projects funded by federal emergency relief programs in 1934. The consultants aided state departments in developing continuous training programs for its public health nurses because of the belief that no matter how well an individual is prepared for her job, unless she is continually improving and extending her knowledge, she becomes less efficient with the passing years. Topics for in-services included venereal disease control, nursing supervision, tuberculosis nursing, health teaching, and program planning. The public health nurse consultant also recommended the establishment of nursing units within each state health department under the leadership of specially trained public health nurses. So the local health departments of rural counties in the South had access to the expertise of a consultant whose purpose was to improve the health outcomes of the public throughout the United States through education and collaboration between the federal government and local agencies. North Carolinians concerned with public health began with the establishment of the first county department of public health in the nation in Guilford County, North Carolina. The American Red Cross employed several public health nurses to provide services to 52 counties between 1915 and 1935. The work of these nurses was supported in the form of office space, volunteers, and supplies. And in many North Carolina cities, different civic, religious, and charitable organizations either started or financially supported public health nursing programs, as was the mission of the Red Cross's Town and Country Nursing Service. The Social Security Act of 1935 provided financial stimulus for the reorganization of public health departments in rural areas. According to Dr. Michael Davis, for the rural Negro, the establishment of well-organized local health departments is the first step towards providing the elements of modern medicine. Rural health departments were not able to make drastic changes through their own local resources. Federal funds and public health work coalitions were a necessity in improving the health of rural Southern blacks. Thanks to the health education of New Deal nurses, the associations between sanitation, nutrition, and environment became more clear, and people came to understand how much they could impact their own individual health. Delivering care to those in rural areas posed particular challenges not seen by public health nurses in urban areas. Rural nurses were often required to improvise with nursing procedures and equipment in order to deliver safe and effective care in the homes of people in remote regions. One obstetric nurse recalls going to a country home only to find that the only thing available for pads were clean rags in a basket in the attic that were damp from snow that had sifted through the roof. In the emergency, being a resourceful nurse, she pressed these with a very hot iron to thoroughly dry, probably making the fabric sterile in a short time. Rural visitor nurses often had to modify their traditional nursing care to make use of available equipment in the home. When the patient's home needed to be sanitized in preparation for delivery, popular sanitizer substitutes were slaked lime, wood ashes, household lye, or strong soap suds, followed by fresh air and sunshine. Food was kept cool in winter by placing it outside of the bedroom window or sunk into the ground in a 5-gallon can and covered. If the patient was in need of a hot water bottle substitute, fruit jars were filled with hot water. Enemas could be used in the home using a funnel, tubing, clothespin, and lard as the lubricant. In a speech at the Kansas State Nurses Association meeting in October 1934, a nurse made the following statement: "We might say the only rule for nursing procedures in the rural home is to proceed as best you can with the material at hand. Truly the most outstanding trait of the successful rural nurse must be resourcefulness." A Claiborne County public health nurse recounts the following story in her notes about a visit with a black family in Mississippi. Her narrative speaks not only to the resourcefulness of rural public health nurses, but also to the community involvement that they encourage. She writes, "A member of a colored hygiene class improvised an incubator for a premature baby using 1/2 pint flask, a clothes basket, flour sacks, and homegrown cotton. The incubator was displayed and it aroused much interest in the community. The same hygiene class is now making a wheelchair from the top of an old chair using wheels sawed from hardwood tree. It is a crude affair to be sure, but will give some convalescent or invalid pleasure and comfort. Rural public health nurses were innovative, able to do their job with little equipment and resources. The vital statistics reported for the decade prior to the Depression reflected a public health need for education on cleanliness and the prevention of the spread of infection. In the period between 1921 and 1930, rural Virginia and North Carolina statistics showed a tuberculosis rate of 106 per 1,000, typhoid fever at 11, diphtheria at 12.5, and diarrhea in children under 2 at 41. And this was for both blacks and whites. But the mortality rates for blacks were consistently higher across all categories. Public health nurses' primary concern had to be with education regarding sanitation and infection control. For blacks living in the rural South, there was an additive effect, a limited supply of doctors and nurses, especially black doctors and nurses, and low utilization of services that needed to be addressed through health reform and education efforts. Mrs. Estelle Riddle, the wife of a black physician, was a pioneer in Negro nursing in the 1930s. Through her work with the Schools of Nursing for Blacks, the National Association of Colored Graduate Nurses, the National Organization for Public Health Nursing, she was able to address the League of Nursing Education at a conference in April of 1935. Her speech addressed the need for increased education and employment of black nurses to meet the needs of the community. To the League of Nursing Education, she stated, "The migrations and urbanization of Negroes have created major health issues. The low economic status of the Negro has aggravated these health issues. The caste system causes a disinterest on the part of a large segment of the public in improving these health conditions. And to a great extent, any program of improvement for years to come will have to be initiated from within the group, spreading through local, state, and national bodies. All the national bodies interested in the improvement of health in general have recognized the important place of the Negro physician, social worker, and nurse in both the preventive and curative fields of medicine. Studies of eight southern states show an average education expenditure of $44 per capita for whites and only $12 per capita for Negroes. There is striking evidence, however, that the employment of more Negro nurses is imperative if this nation is to make any constructive steps towards meeting the health challenge thrown on it by the Depression. Too long the emphasis has been on racial differences. We need a new deal and approach to community problems in order that we may recognize racial similarities. Any group, white, black, or red, subject to unhealthy environmental influences will present an unhealthy social picture. The Negro nurse is a part of all that affects Negroes. When well prepared, she is the best person to work among them for their improvement." The limited availability of professional training programs for black nurses, particularly in specialized fields like public health, was yet another critical issue in the health care of blacks. The public health nurse is at the forefront of public health education, and with black women having fewer opportunities for training in the field, the needs of the black community were difficult to address because, according to Mrs. Riddle, the Negro nurse is a part of all that affects Negroes. There was a challenge in training black nurses in that most training programs for public health nurses were up north. One had to have adequate educational background that usually required having the financial means for formal education. Most nurses who trained up north did not return to the South, and most importantly, many training programs did not admit black nurses. The 1930s started to show improvements in the opportunities for the training of black nurses. In the late 1920s, there were less than a dozen black nurses employed in the whole South. By 1937, that number had multiplied 12 times, thanks partially to the interest and cooperation of the U.S. Public Health Service, federal funding, and a number of southern state health officers. In 1934, the United States Census showed not more than 200 black public health nurses in the entire South, where the population of blacks was approximately 9 million. That number of blacks grew to 500 in 1937, giving a ratio of one black public health nurse to every 45,000 blacks. In the best scenarios, this ratio was not significant to meet the needs of blacks. To get a better picture of the differences in ratios of nurses between races during this time, you only need to look at the comparison of the ratios of black nurses to white nurses across the nation. 4.8 black nurses per 10,000 black Americans and 26.5 white nurses per 10,000 white Americans. One approach to addressing the differences in the ratio of black to white nurses was to focus on improving educational and professional development. Mrs. Estelle Riddle was particularly adamant in this approach and was a leader in encouraging black nurses to unite and join professional organizations. She expressed that the low socioeconomic status of blacks, as well as black nurses, hinders progress in improving health care. Of the black nurse, she says that where her services are most needed, she is poorly paid and must travel thousands of miles to gain admission to a graduate nursing course if she wishes to improve professionally. Mrs. Riddle believed that the establishment of a public health nursing course at the Medical College of Virginia prepared at least 75 black nurses for jobs in the South, thanks to Social Security stipends. She recommended that black nurses continue to unite professionally through organizations like the National Association for Colored Graduate Nurses. The National Association for Colored Graduate Nurses was able to establish scholarship funds for nurses pursuing a course in public health nursing. One approach to dealing with the public health of blacks was to educate children on sanitation and health. Winston-Salem Teachers College in Winston-Salem, North Carolina, integrated health education into the teachers' training curriculum with the approval and cooperation of the state's Departments of Health and Education. The basic premise was that family life directly impacted the health of the individual as well as the entire race. It was noted by Franklin Nichols of the American Social Hygiene Association that the progress of blacks was dependent on improved economic conditions, more equitable education opportunities for Negro children in the southern states, and finally, the continued development of the appreciation of family values, ideals, realities, and obligations within the race. Theoretically, by moving health education into the schools, one could impact the current and future health status of an entire family. In addition to educating children in the schools, public health workers also educated the adults throughout the community. One Mississippi rural health nurse says about the value of education in nursing care, each communicable disease case contacted is given the reason for doing the things asked, and thus better understanding brings better cooperation. This same nurse in Claiborne County felt that the public was eager for knowledge. After lecturing a group of housekeepers, she felt that they were very much interested and ready to cooperate in every way with the health department. The public health nurses in Mississippi established trust with the community, within the community they served, instilled a sense of value in health education, and established a partnership that fostered continued growth in education. Tuskegee Institute, founded in 1881 as a black institution, worked in cooperation with the U.S. Public Health Service, state boards of health, and the National Health Council to institute National Negro Health Week in a joint effort to improve the health of blacks through community education. The program provided a week of intensive focus on hygiene and suggestions to improve the actual racial health conditions. The effort involved the preparation and wide distribution of specially prepared health education materials to churches, lodges, schools, and colleges. The relationship of public health workers with the community was strengthened by the lay midwives, most of whom were black, and their strong dedication and service to their community. Black midwives, also known as granny midwives, were part of a network of public health workers that included doctors, nurses, ministers, and teachers. Indeed, were it not for the black midwives, state and county health departments targeted to the black community would not have been as successful. Midwives were respected members of their community, as influential as the preachers sometimes. They were preferred by black women over physician deliveries for multiple reasons. They would travel further to provide care, they were much cheaper, they provided additional services like cooking and cleaning, and they treated the rural poor with dignity. The black midwives were initially targeted as part of the problem because of their unscientific practices that were seen as unsafe folk medicine. Health officials successfully eliminated the older granny midwives that they deemed too old to train, although according to historian Susan Smith, their safety record was similar to the physician safety records at that time. The remaining midwives were educated and certified to provide safe sanitary care. The granny midwives then became instrumental in the public health movement in the South. Health department officials learned the value of having respected members of the community play a role in developing and implementing health education programs. The granny midwives often accompanied public health nurses in home visits to mothers. They also gave health lectures at church, referred community members in need of care to physicians, and encouraged people to go to local churches for typhoid shots. Nurse Neil Austin of Forest County in Mississippi indicated that the midwives are she's one of the public health nurses there. The midwives are very helpful in getting the colored people immunized against typhoid fever. At the last midwives meeting, they were asked to round up all the children in their neighborhoods and bring them to the health department and have them inoculated against typhoid fever. One midwife was in the office the very next morning with 55 children. The midwives were also advocates for the poor, insisting on increased care from doctors and nurses for poor women. In Mississippi, they provided health education to adults and children in both schools and churches and acted as liaisons between the white health professionals and black communities. In one case, a midwife, Estelle Christian, notified the public health Viola Jones that a middle-aged woman with sores on her arms and legs had to come for a visit with the new mother and baby and was turned away by the midwife. This is what the midwife wrote. Now could you go out there once to see about this? I made a lecture on the fourth Sunday in August at a church in Willows, Mississippi, to the people about their health. I advised them if they had any sores or the least suspicion that they were infected with that dreaded disease syphilis to please tell someone before it's too late. So she says she heard me talk that day, and when she heard I was in the neighborhood, she came to tell me about it. So I advised her to stay at home until I talked with you. So if you could, come out here one day. I could go out there to the homes with you. Midwives aided in the control of venereal disease by encouraging people to be tested. Because of the trust they had already earned, they could broach sensitive topics and impress upon the community the need for testing and treatment. During this time, venereal diseases were a major public health problem, and midwives were effective in distributing literature in churches, schools, and homes, and were effective in reaching teenage girls that were infected with syphilis. The widespread conclusion among public health workers was that the health of the most vulnerable directly affected the health of the nation. The North Carolina Mutual Life Insurance Company and similar agencies across the South reported high rates of morbidity and mortality among blacks. Widespread education and nurses training measures were initiated to improve these statistics. In addition, progressive public health workers attempted to dispel the myth that differences in disease incidents were because of race, rather a result of correctable environmental conditions. The health and education needs of blacks during this era were addressed specifically by many national organizations. Much work was done to understand and alleviate the barriers to health care that impacted blacks in the rural South through the collaboration of doctors, nurses, midwives, and community organizations. While the efforts to educate poor rural blacks were important to address the health concerns of that time, the major problem of economic poverty remained the unmovable force and, quote, the greatest cause of Negro sickness and death. Thank you.